Welcome, everyone. Welcome to the Dying Your Way podcast. It is a great delight of mine to have two experts in the field of HIV and AIDS, and that could be one of the topics that we talk about today. But it's a married couple of 31 years, Peter Oates and Gary Paul Wright. And Gary Paul is very much involved in the co-founder and executive director of the African American Office of Gay Concerns. And for 22 years, he has been providing AIDS prevention services to the community in the New Jersey, New York area. And Peter is the director of healthcare services, School of Nursing at Rutgers University. And he has a background, you'll hear his accent, he's from London, but he has a background in intensive care nursing. But he's done a lot of work in the HIV community as well. And both of them have many affiliations and many awards, but they both have these sparkling personalities, and you're just gonna love meeting them. And here I go, I'm gonna introduce you to Gary and Peter. Hi, guys.
Hi, Claire.
Lovely to see you.
Oh, great to see you. I mean, when was it that we met in New York and had the coffee? That was...
Oh, man.
Oh, my Lord. Don't ask me.
Oh,
it's
man.
been, I mean, we've stayed in touch through Facebook,
Right.
but it's really been
Right.
a long time
Right.
since
Wow.
I've been with you. And Gary Paul and I went to college together. And as I was preparing for this interview, I couldn't help but think about all of our friends that we've lost, you know, really of this very tight circle of theater community that we were part of. Gary Paul and I and Mary Lou, we're the ones that are alive and the rest of them are gone.
Yeah.
So we've suffered loss through the AIDS epidemic. And one of the things that I realized that 36 million people have died of AIDS, and that 37 million are living with AIDS right now. And last year, 700,000 people died of AIDS. And we just don't hear about that. I mean, obviously, we've been thinking about the coronavirus, but one of you shine a light on that for me. Why don't we even talk about that anymore?
You know, it's because it's been going on for so long. What we're talking about, 40 years?
Yep.
And here we have a coronavirus that they developed a vaccine for within what? How many months?
Okay.
And after 40 years, we still have a vaccine for HIV. And it's really disheartening, you know, working in the field for so long that we haven't made that progress as much as we did with COVID.
Yeah, and it's like after a while, you know, they keep saying, "Well, we're breaking ground. We're almost there, and we may come up with something." And yet they keep coming up with, more and more treatment, which is good. We like treatment, and treatment can be prevention. But you know, it's like, come on, guys, it's been 40 years. Jeez.
I mean, I will say that with the research done with the COVID vaccine, I think they're going to be able to use that research to sort of really now start addressing the HIV.
That was what I
vaccine.
was going to ask you. I mean, it just makes sense.
So I think, you know, it's good and bad. You know, it's taken us 40 years to get to this point, but I think good comes out of what's happening at the moment with the COVID pandemic.
But still, when you know that 700 people have died of AIDS, that means that there's a big hunk of people that aren't getting the cocktails that are given so they can live. What's up with that?
Well, a lot of people, first of all, don't even know that they're, you know, infected. So, you know, that alone is disheartening. People either know either they know they're infected and not doing anything about it, or they don't want to know. They might think they, you know, might be, but they don't want to know for sure. So, you know, of course, they're out there still spreading the infection, HIV. And we don't really talk about AIDS that much anymore. It's more about HIV and HIV infections and things like that, but people still do die of it. So
I mean, we are making great strides. I mean, you know, here in the United States, that every state is now developing an end the epidemic plan, and New Jersey
a
actually
what epidemic plan?
ending the epidemic plan
Okay.
for HIV. And Gary Paul and I were both on the task force of the New Jersey state to sort of develop an ending the epidemic plan for the state of New Jersey. It's taken 2 years to sort of be approved by the governor, but it was just approved.
Yeah.
But I think this is happening all across the states to really start, honing in on ending this epidemic for good.
Yeah.
And so there's a lot of work still to be done, but we have a plan here in New Jersey for 2025 to reduce new infections, get people on medications, and reduce the viral load. So,
Okay, so
there's hope. There's hope.
so you know how we've seen the coronavirus mutate and change so much. So in the 40 years, has the HIV virus changed and mutated? And is the disease different now than it was when our friends were dying?
Yeah, that's what viruses do, right? They mutate all the time. So, the coronavirus mutate is no different than any other virus. And so we have seen the HIV virus mutate over the years and continues to mutate. And if people don't take their medications every day, that's the window of opportunity for the virus to mutate into something that will become resistant to the medication. So, just being on medications is good, but you need to take it every day in order to be effective and stop these mutations.
Right.
So there was I don't know if it was a theory or if they've kind of gotten down to patient zero about the Omicron variant, but that they suspected that it was someone that it was highly immune compromised, probably with HIV, that that virus could mutate and shift because of the lack of care, I guess, they were getting from HIV, for HIV.
And that's kind of why we were like really pushing for people to get vaccinated. Even most of my staff got vaccinated right away, but we still had one lone holdout, and she finally got her first dose Monday. So we're happy about that. So, but oh my goodness.
Why was she holding out?
Because she just grew up that way. She's from Atlanta. She's trans, and she just didn't. Her family was raised that they really didn't, get vaccines and things like that. I think they might have gotten, the childhood ones initially, but she was just resistant to it. I didn't find out until last week that she wasn't even on hormones. I mean, she's a large girl, and she's very femme, but she's a tall girl. Yeah. And I thought she was already taking hormones, but she was scared to death of taking hormones. And it was like, oh my goodness. So I kind of gave her a pass about the vaccine. Yeah. She just doesn't like needles and things like that. But now she knows it's going to save her life. So. Oh,
I mean, I have a real phobia of needles, and boy, as soon as I was eligible here in Australia to get the vaccine, I mean, Terry and I went to get the vaccine. So we could, at the time, we thought we could easily travel back and forth to the United States once we were vaccinated. Well, in Australia, they have just shut down the border in Western Australia. And even though the rest of the country is opening up, they're not going to open it in Western Australia up until they reach a 90% vaccination rate.
Wow.
And there are so many holdouts of people that for different reasons don't want to be vaccinated. Yeah. People that are really smart and intelligent. And boy, they, a lot of people have gone down a rabbit hole,
Yeah. A lot of my patients still, don't want to take the vaccine, but it's mainly in the African American community. A lot of my patients are African American, and there's this real fear of getting the vaccine, and so you have to have those conversations with them on a regular basis. And I must say that gradually they're beginning to get it, but it's taken a while for them to come up to speed with sort of trusting the healthcare system. To be able to take that vaccine. So.
But what kills me is these anti-vaxxers and people like that, once they do get sick, where's the first place they go? They go to a hospital, okay? And they're asking the doctors to say, and the nurses to save their lives. It's like, now you trust them, okay? Because you're dying, so but you have to be sympathetic. You just, because we need to wipe this thing out. So
Yeah. Yeah. I've had to curb my judgments that I are there, but it's because a lot of these people are people that I love,
right.
Yeah,
and
absolutely.
but I just want to get home so I can see my granddaughters.
I know.
And I can't do it until
It's very hard. It's very hard.
It is hard. So, Peter, in the work that you do as a nurse practitioner and clinically, and you say you work with a lot of African Americans, well, Gary too. I mean, I just want to get, when they come, whether they have a slow progressive illness or generally a slow progressive illness,
Sure.
and they are diagnosed, at what point do they get palliative care?
Well, getting palliative care, by the way, doesn't mean that they're dying, right? So
Correct.
Right. So you sort of have these conversations. Luckily, most of my patients are doing extremely well, and they've sort of gone back to work, and they're thriving. They're having children. So the conversation about palliative care doesn't come up because there's no real need. But having said that, you still sort of address it, in general conversation with patients, whether they're HIV positive or not.
Mm-hmm.
It's one of those conversations that really often doesn't take place. In my experience, it's been, in trauma, when someone's in trauma and they're in the intensive care unit, and then certain decisions have to be made and no one's thought it through before. Right. And I think this is what you're doing is incredibly important, because it's all about not particularly the healthcare providers who need to be educated, although they do, but it's the general population have to be educated and know about what palliative care really is about. It's about managing a chronic illness in a way that's a good pathway to whatever. So I think what you're doing is incredible. I think that's where the grassroots level education needs to take place.
Well, I mean, I do work with a lot of dying patients, but nowadays, because of medical technology, you can get a terminal illness, say congestive heart failure, and live for 20 years.
Right.
But you're going to end up dying of congestive heart failure unless you have a car accident. I mean, that's what's going to kill you.
Right.
And I really encourage people to get early palliative care, and you have to educate and train them that doesn't mean hospice.
Right,
the hospice only comes in when you're in
right? Hospice and palliative care in people's brains is connected.
Yep.
Yeah, I mean, so hospice is when it's terminal condition and you are in effect dying. That doesn't mean you have to suffer from pain or anxiety or have these psychosocial needs that aren't being met, and just wait until you're actually dying to get that. So there's, and I think one of the frustrations that I have when I look at statistics and stuff for the African American community is that there is so many good medical options out there for people with terminal illness that they don't have access to. They don't have access to because I think, I'm just going to say this. I think African Americans get treated differently in a healthcare situation than white people.
Absolutely. I mean, look at pain management. I've seen patients in the hospital, African American patients, who are given sort of a mild analgesia, whereas white folks get the really good painkillers, the opioids. But there's this in the healthcare industry. There's this myth that African Americans are use drugs, and so we shouldn't be encouraging the drug use. So we don't give them good pain management. And this is real. This happens. You see it, when you're in the hospitals, that African Americans get treated differently than white folks, and that's a reality. We
were just watching Wanda Sykes the other night on
her special. Her.
And it was so funny. And she was talking about, white folks, are on opiates, we're talking about the war on drugs and things. She says, you white people get opiates, opioids. We black people don't. Okay. Because when we go to the, when we go to the doctors, they say, oh, walk it off. You'll get better. Okay. Right. Meanwhile, if you're white and you're in pain, here, take this medicine, you'll feel better and blah, 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 blah. So it's so funny that, I mean, she's using it as a joke, but it's so true.
But it's very real.
It's very real. Yeah.
And it's not just pain medication. It's healthcare across the board.
Yeah.
Accessing it and getting quality healthcare really is awful in that community.
Well, and it's the same here with the Aboriginal community.
Yeah, absolutely.
And I'm sure with, American Indians and all sorts of different, because one of the things that we try to promote globally everywhere is people having access to quality end of life care. And what is quality end of life care if it's not a palliative approach to that? So Gary, tell me about, I know your family in Texas. Have you had family members or experienced death and dying in your family where it was less than how you would want it to be?
Actually, I'm going to tell you, my parent, I lost both my parents and I lost my sister, Kim. But both of them, all of them were like, my father worked at Presbyterian Hospital, so he was, cool. And when he got very sick, he went to live in San Antonio and with my sister, because she was still alive then. And but my mother, even because she worked at State Farm, she had great insurance, so they were both very well taken care of. And Kim was also a nurse, so when she got sick and she was in care, they all got very, very good care. But it's because we're part of that family, and we know the system. My dad and my mom, they were all involved in it. But your average person, especially in Texas, they don't know these things. They don't know, that they have a right, to die, painlessly. You know what I mean? It's amazing that there is that difference. But you've met my parents, right?
So, yeah, they came to all our shows.
So, my dad loved you, yes. So they always came up to North Texas to see us performing The Boyfriend and stuff.
God love them.
But so we were lucky. They were very, very lucky. Now I have to admit, I was in California and in New York, New Jersey, when they all passed. So I wasn't really there 24/7, like my sister was or my brother was. So I maybe I just heard all the good stuff, but I never heard anything negative or bad when they passed away. So yeah. But again, it's because we are who we are, and we knew what to do.
Right.
Yeah. And even people that are well connected or white, whatever, there's still a lot of fear and denial about death and ways people approach it, that is doesn't support the process. I really believe our body is naturally wired to die easily. And the same way that we've put a lot of effort into planning births and how, that's going to be a positive birth experience. I mean, we really love to focus on creating an environment and supporting the family so they have a positive death experience, because those memories just last with you forever.
Absolutely.
Forever.
I have a story about my own personal experience with death with my father. I was over here in the United States, and it was like 18 months after my mother had died, and he didn't want to be around anymore. What was there to live for, apart from his kids, of course. Right. And he gradually deteriorated, and my brother was doing all the stuff. He was 4 hours away, but and so my father was getting frail, and the district nurses were coming in to take care of him. But his GP kept putting him into hospital when he sort of, got a little ill. And my dad in the end said, I don't want to go back to hospital. I want to stay in this bed where mom died, when your mom died, and I want to die here at home. I mean, he expressed that, and he wasn't a talker, really. Yeah. And my poor brother got a call from the district nurses one day to say that the GP wants to put him back into hospital again, and he's not telling your father. And so my brother drove up north, and he actually changed the GP to this really young GP who got it. And towards the end of his days, I went home and I was able to take care of him. My brother and myself took care of him for like 7 days. I did night duty, he did day duty. And then eventually he passed in his own bed. And when the GP came to sort of certify him, he came downstairs and started crying. And
The GP
the GP
was crying.
not GP,
Not just
the doctor,
GP,
the doctor.
Yeah.
General
practitioner.
And he said, I just want to thank you for allowing me to take care of your father until he passed in his own home. He said, the healthcare systems these days, they ship them off to the hospital, and I never get the chance to see that last event. And so he was very emotional. And he said, can I use this as a case study? And so that was a positive experience for me in terms of my father passing away.
Actually, there's a little bit more to that story. Remember when you were there and you and your brother actually thought he had passed away that afternoon, and they were downstairs crying and da-da-da-da. And then they went upstairs and Dad was there, I would die for a cup of tea, didn't he?
Yeah.
Something like that.
He was having chain strokes, and so he would stop breathing for a length of time, and then it was a long time. And I said to my brother, I think this is it. And then all of a sudden he woke up and said, oh, I'm dying for a cup of tea.
The rally, the end of life rally.
Yes,
Okay.
exactly, right? It should be a smooth sailing, right?
But see, if people don't experience watching their parents or someone die, and what you've got to say was a good death, if people don't see that and experience that, then they don't know what to shoot and plan for their own death.
Exactly. Yeah. There's
It's
a great
almost like
void in knowledge around, how you deal with death and dying and chronic illness. People just don't want to talk about it. Or maybe they do, but they're just not given the opportunity to. So.
They want to talk about your death. They just don't want to talk about their own death.
Right.
You're going to die, but I'm not.
Right.
Actually, I'm surprised that I'm this old. Really, I never thought I'd go past 33, 34. You know what I mean?
Well, back in the day, you didn't know, right?
You didn't know, right?
So. I mean, did you ever? You don't need to tell me. Did you ever test positive for AIDS?
No, HIV. No, I'm still HIV negative. So.
Oh wow!
Yeah.
How did that happen?
I don't know. In fact, if you watch the Tub Talk, you'll find out. I go into that in the Tub Talk.
Oh,
okay?
really?
Yes.
Lord. Can't wait for that one.
Yeah. No.
Well, you were at the front of teaching safe sex. I know that.
Right.
So.
Right. But I was
that makes all the difference.
But I was out there, so
practice what you preach.
There you go.
Yeah.
There you go.
Yeah. Oh my goodness. Now, Peter, you actually weren't you doing some nursing for the royal family or a royal or someone? Tell us about that.
I did. Yes, I had that opportunity. I was the private nurse to the Earl of Althorp, Lord Spencer, Princess Diana's father.
I love that.
And so I had the opportunity to take care of him, and
was that in his home or in a facility?
No, it was actually, he had a massive cerebral hemorrhage, and I was called to take care of him like immediately. And I went to take care of him. He was expected to live for 2 weeks, and he survived.
But you took care of him at his home or in a hospital?
No, intensive care unit.
Okay.
He was in intensive care for a long time, and then he developed lung abscesses and went to another hospital. But then eventually I did go home with him to rehabilitate him. So I lived at Althorp for quite a long time. And I met Princess Diana when she was 17 years old. And we became, we corresponded, and I was invited to their wedding. So I went to the royal wedding.
Wow.
And they know about him too. So,
and yes, yes. Diana knew about me, and she actually wrote my name in a letter. So,
oh my goodness,
I never got to meet her, but she wrote my
goodness.
name in a letter. So,
no, but I mean, so you have really experienced at the very top of the medical treatment chain, people getting the very, very, very best of care, and at end of life care as well.
Yeah, absolutely. Yeah.
I just have such a strong need for equity that I just want everybody to have that kind of care.
It's a no-brainer, right? But over here, I mean, the healthcare system over here, actually, I'm retiring at the end of February after 54 years in healthcare.
Wow.
I'll be 70 in January, and I promised myself when you reach 70, you need to retire. But part of the reason that I came to the conclusion I need to retire is I cannot deal with the healthcare system anymore. You know, I spend ages trying to justify my treatments, and insurance companies deny what you order, what you prescribe. You know, they're micromanaging how you deliver healthcare, and I can't deal with it anymore. So
Well,
I'm saying goodbye to healthcare.
well, okay. So you're going to retire from being an active treater of people that need your treatment,
Right.
but
Absolutely.
but maybe there'll be a new path that you'll go to change that.
You know, I don't have a plan. I chose not to have a plan. I just want to ease into it nicely. But, you know, things may come up, especially with this one. He's always coming up with ideas and what we need to do and da. So I anticipate maybe something may come up. I've got some ideas in my head regarding trans populations, but a similar thing to what you're doing actually is sort of.
Oh, well, then we definitely can. I'm happy to share anything, resources, because I know a lot of really good people that are very much pioneers in this field that have been mentors to me. And
Cool.
yeah, it really is. I don't know why everyone doesn't have a doula when they die. You know, I mean, they are really trained to anticipate the transitions that happen before they happen, to make sure that those resources and circumstances are in place. And I
It
guess
should be an integral part of the healthcare system, right?
it really should.
I mean, it's those sort of things like the doula for childbirth. It's like it should be integrated into the healthcare system to provide that holistic care. So there's a long way to go.
From your mouth to God's ears, we'll see. But but let's talk about you guys individually. So if you were going to be honest about what really worries you individually about your end of life, or even as a couple, you know, because one of you will go and the other one will be left behind. I mean, what is your greatest worry right now around that? Gary Paul, you go first.
No, I mean, my worry is for him. Like, if I was to go, I'm cool with going. You know, I think we both are. We're both accepted that we're going to go at some point. But I often think, well, not often, but I think about, you know, what is he going to do when I go? You know, how is he going to be? Is he going to be okay? So my thoughts all around him. Not me passing. It's what's going to happen afterwards. In fact, we started this conversation again recently, applying for my pension. It's like, oh my God. You know, if I go first, if you go first, it's like, oh my God. So we have those conversations.
I made my will years ago, though. So, I mean, I'm covered. I mean, not that I got a whole lot of stuff to get rid of, you know what I mean? But, you know, I just wanted to make sure. And plus, if he went before I did, which I don't know, you know, I wanted to make sure that someone in my family was going to, you know, inherit, or, you know, my little stuff, and not the wrong people. I don't want the state, you know what I mean? I don't want, you know, they can't have my house. But you know, but he just started recently because of this whole pension thing. And I think that's one of the reasons why we're doing this, because when we first got the invitation, we were like, oh man, we don't want to talk about dying. What do we,
like everybody does.
That's no fun.
You know, that's, you know, right. But then, you know, reality sits in. And plus, when he said he's going to start retiring, it was like, you know, we got to sit down and talk about this stuff. So, and, you know, so we said, well, you know, we might as well talk to Claire.
We both have advanced directives, right?
Right.
So that's sort of done, the advanced directive sort
that's
of thing.
Good. That's good.
That's all done. So,
I mean, so I really have, both of my parents died at home, different times, but both of, I made a real point that, you know, I custom built the house that I have in Texas. So it's all ADA compliant and high toilets and grab bars. And, you know, it's it was designed for that. And in the back of my mind, I'm like going, ooh, I really like these high toilet seats now. I really like this grab bar now. And
True. So
I
true.
want to die at home. I want to die at home. I do not want to be in a medical facility
Right.
at all.
Right.
And I feel so strongly about that. And I had done an advanced directive, redid it with Fred Merarkey, who does this Mideo card where you basically are, I'll show it to you sometime, but it shows, it's like a doctor speak in an emergency room, what to do. And, you know, he really advised me that, you know, he says, you doulas, you're just too comfortable with death. He says, you probably have 20 years left and you want people to do CPR on you. But so, I mean, I really just want to be sure that when I do get in that terminal condition, I really want to be at home. I really do not want to be in a hospital.
Absolutely.
Yeah.
Yeah. I agree.
And I work with a lot.
That's what my father wanted, and it happened. It was a wonderful thing.
Yeah. So being a strong advocate for each other, you can make that happen. You know.
I have a very strong advocate.
Nobody messes with us, okay? Nobody, okay? We say jump, they say how high, okay? Yeah, but we're you know, I mean, we're like, you know, two peas in a pod. I mean, we are a couple. I mean, people don't think of one without the other. You know what I mean? If I pass gas, Peter's going to know about it. You know what I'm saying? So,
everybody knows about that.
Shut up.
But my mother used to call. She used to call every Sunday. And one of us would pick up the phone and she'd say, is this my black son or my white son? Because we answered the phone in exactly the same way.
And my father was the same. He didn't know who he was talking to.
He had no clue. He'd be rambling on about something, and I said, Dad, I don't, this is Peter.
It's Peter, your London son.
And
oh, God. But I mean, and that's the thing about us. Our families were so cool with each other. Pete's parents came to visit us, you know, several times when we were in Jersey City and when we got this house. After your mom passed, your father still came over. He was like 92, 93 years old. My father, you know, visited us often, and we took him to England and we stayed at his parents' house. And it was just like, or your brother's house, but that everybody else was in the house too. And it was just like, you know, one big family, one big happy family. So, you know, which was funny because I didn't think my father would ever, you know, enjoy having a queer son, you know, but deep down inside he did, you know. And when we first went to England and we said, Dad, you know, we're going to go to England. Would you think you might want to go? And he was like, oh, well, I'll think about it. And we found out he went and got his passport the very next day. So, so he was very excited. So
he's a very cool man.
He was okay.
Oh, that's wonderful. Yeah, it was. I mean, honestly, Gary, we've had so many good times over the years. And I just treasure, you know, all of Chris and Jimmy and Paul and young David. And yeah, it's just so sad that they're gone. I know.
I think, you know, the feeling in the community now, as far as HIV is concerned, I think there's less fear of getting sick and dying because they know that they can get medicines and things like that. I do think the COVID whole thing with the COVID thing kind of brought it back home. And it's like, okay, you know, stuff is still happening, but I don't see the young people like, say, maybe 20 years ago when we started the AALGC. They're not as, you know, they're not as doom and gloom as you know, they used to be. You know, there's still a little bright stuff going on with their lives. So, and that's good, because for a long time, the gay community especially was just so down and everybody was dying. And my God, you know, my singing partner, Willie, and I would sing at, you know, this funeral this week, and, you know, we'd have another one in 2 weeks. It's like, oh man, you know, but yeah. I think that's another thing that kept me going, and you know, just like I'm not ready to go yet. So
Yeah.
I'm stuck
Well,
with him.
if you were like looking into the future and wanting to change healthcare at the end of life, not just for yourself, but for everybody, people that are a part of your community, different parts of your community, what is working or what isn't working or what needs to be put in place? What are the things that come to mind?
I think preparing the workforce, the healthcare providers, that they get these lectures on palliative care and end of life, but it's not integrated beautifully into the healthcare system. So having some integrated system that includes palliative care as a norm is the way to go. It has to go that way. And, educating providers, but also what you're doing, educating the community about it. And families, because I think there's a disconnect in how to communicate with families at end of life or during palliative care. That conversation doesn't take place with the healthcare providers and the families in preparing them in the correct way for that. And so a lot of work needs to be done on that, and the quality, evaluation of programs and seeing whether they work or not, and monitoring the quality of the care that's given to improve the standards of care.
But it's like, we both, know we want to be cremated, right?
Mm-hmm.
We had
or planted.
Planted. But I don't know. I don't know where I was going with that. I'm sorry. I just
but that's part of it is figuring out, what you want to do with your body at the end of life. And we could have a whole talk just about that, because I have some ideas I might share with you. But what you were saying about palliative care, Peter, I actually talked to a doctor here in Southwest Australia. Wonderful. She's a GP, and she's works from babies to people that are dying. The whole spectrum. And we were kind of riffing about palliative care, if it was introduced at all stages of life, whether it's, say, someone has a mental illness or someone has an addiction problem, or they have a wreck that they're, changes their whole life, that there is like a palliative approach to all of those really health crises that could be life-threatening. They maybe aren't life-threatening, but they still need that palliative care. And if that was in the medical system from womb to tomb, then when it comes about at end of life, people wouldn't think, oh my God, you're ready to give up on me. When nothing's further from the truth, we'll do curative treatments with you as long as you want to, and then when you say stop, we'll stop.
I think there has to be more emphasis on sort of putting it into the curriculum of medical schools and nursing schools and social. It has to be part of the curriculum, and it's like HIV. They get like a 2-hour lecture on HIV, and that's it. You're done.
Or trans people.
Oh God, he does a lot of work with the medical school and educating about trans care, and so it has to be incorporated into the curriculum to train healthcare professionals that this is the norm.
Tell me
a long way to go with that.
You're reacting strongly about the trans care. Tell me about that.
Well, even with HIV for many, many years, if a trans woman, let's just start with trans women, if they got sick and things like that, they would, or if they died, their statistics would go to the men's column. Okay, they wouldn't put them in the women's column because it was, they were born a man, they have a penis, whether they have one or not, they're trans. So, so they, and when we opened the office in 2002, we went along with that because we didn't know any difference. But once we started having trans people in the office, and I could see the difference between, gay men and trans women and what they're going to need to battle HIV. It was totally different. It was just totally different. A lot of these girls
like
were
what
Well, for
Specifically
instance,
what?
they were a lot of girls were sex workers, right?
Mhm.
So a lot of like doctors and things like that didn't feel like they wanted to take care of them because, oh no, you're out on the street, you know, I'll give you something for your chlamydia, but you know, that's about it.
Mhm.
But the fact that the State Department of Health would categorize them under MSM, men who have sex with men, was like terrible. And what's that going to do to your psyche? You know, what's that going to do?
Mm.
How are you going to feel? It's like they don't even treat me like I want to be treated. So when we
Mhm.
asked the state for money specifically to deal with trans women, to do outreach specifically to trans women, to develop programs specifically for trans women, you know, and they finally agreed, and it's just a total, you know, a new dynamic. You know, now everybody's on the bandwagon. Everybody's got a trans program now, but we were the ones that like really.
So what
really
changed though? What was it specifically that changed for them?
Well,
that helped?
Well, education for one thing.
Mhm.
Okay, education in how we approach them. Okay, it's not like these are not all sex workers. Okay, it's also giving them jobs. You know what I mean? It's like, okay, these girls got to eat like everybody else. You know what I mean? So, you know, hire them. You know, they're real people. They just, you know.
But he touched on a point about the statistics. So if you're not collecting data on trans folks, how can you justify funding programs for trans folks when the statistics in the States say there aren't any in the state?
Right.
And he was the first one to start giving the state trans data separately.
Right.
And they used to clump it into MSM data, men who have sex with men data, but he would submit them separately. And eventually someone at the state got a light bulb went on. And so now they're collecting data on trans, and it's amazing how the statistics are now shifted about we have a lot of trans folks in the state of New Jersey. We need to address that.
And you were talking primarily about the benefit was the psychosocial support that they are now receiving because they're being accurately reported.
Right.
Correct?
Right.
And so psychosocial support is a big part of palliative care.
It's a major part.
Yeah.
I would say it's a major part.
Yeah. Yeah.
Yeah, absolutely.
I think we should rule the world.
We do, don't we?
I don't want it. Y'all can rule it. I'll walk behind you and throw rose petals on you or whatever. Okay, but I don't want
you guys. I just love you both so much. I really do. Hey, listen, so I really appreciate you coming on this podcast and really shining a light on, people don't know a lot about trans people and their healthcare problems. You know, they've forgotten about HIV and AIDS, and it's still a really huge issue that hopefully because of coronavirus, we're going to see turn around and get that under control. If any of the listeners have more questions, what would be, I don't know what they would question about, but I could see them wanting to know more about particularly what you're offering, Gary. You know, if they needed some sort of psychosocial support, and what they're going through, how could they get in touch with either one of you?
Yeah. We have several Facebook pages.
Can we put it in the chat?
Can you put it in the chat?
Can we put our emails in the chat or?
Yeah, well, I'll just be sure and give it to me, and I'll be sure it's a link when I put it on YouTube and Apple and it'll be, those links will be there. So if people are hearing this and you want to reach out to either Peter or Gary Paul, then I encourage you to do that. You don't have to suffer alone. You just really don't. There's a lot of help out there, and
and we're also like, if we don't have the answer, and we don't have all the answers, we have resources, and we will find the answer if somebody gets in touch with us. Google African American Office of Gay Concerns. That's my office, the AAOGC. We have Facebook pages, like 4 different Facebook pages, but we're around. So, but if they just want to hit us up, if you want to supply the emails, that's fine too.
I just have to say, he has a great program called TGIF. It's Thank Goodness I'm Fabulous. It's for the trans girls.
That's our trans girls. We have the Brother Project for the boys and TGIF for the girls. So.
He wakes up at 4 a.m. with these ideas and writes them down. So, for God's sake.
But now, what we're going to be doing now is working with trans men. which is, they've been left out. Even all the work we've been doing with trans women, there's trans men, man, that need some help too. So that's what we're trying to get funding for now. So,
well, thank you so much for the work that you're doing. I mean, it's just so important, and I just feel good that we're talking about it, and that the general public, who never thinks about these things, have an opportunity to humanize, the human experience we all go through, and we all need love and support, particularly at the end of life. And
amen.
And thank you for what you're doing.
Really, thank you. I mean,
I know I checked out your website, so I know you're doing good stuff.
He Googles. I'm telling you, he's the Google king. Let me tell you.
Well, I'm gonna get you guys some more information too, because
Okay.
I mean, I can really offer you guys, or I have a lot of certified end of life doulas that are very capable to help people at the end of life. So
cool.
And that's something I don't deal with. I mean, I don't know about. So you're educating me and us, at the same time. So well done.
We're all in it together. Okay, guys.
I'm gonna go out and do the Riviera. Okay.
Do.
The Riviera. Okay.